A very good evening to all of you. As promised in the schedule, that after 4 modules, we'll be putting up a live quiz session, and we are back with a live quiz session. This was actually planned, which was probably not done in the prior 2 batches. We thought that 2 months is a long time to make sure you're engaged, and we know that you're around and you're with us in the course journey. We have put up these live quiz sessions so that you can, feel activated by appearing these questions. That was the whole plan. And then have a live debrief video, because many of you may have felt that all the videos are pre-recorded. So that was the reason we came up with this live quiz session. So as I said, some few pointers I wanted to mention. The reason we have kept this 2 month schedule, which I had already mentioned prior in the free webinar also, that because the course is too much, it's very difficult to sit and study on your own. That's why we have put weekly modules so that we can help you to cover as much as possible. Now, we have given you all the study materials in the form of articles, where every module mentions as a must read and optional. Understand the fact that we cannot give you notes and PPTs. I think many of you had the concerns for that. Notes and PPTs are not possible. We are giving you articles so that you try to assimilate the important information from that which is useful to you, right? Some person may think, I already know this, let me write the other important points from the article. So at this stage of life, giving notes is very difficult when the course is so vast. But still, we have tried to make sure the articles are concise, they're not too boring, easy to grasp, and we have cut down on the must read articles so that you don't have to go through a lot of them before writing your, before revision or before writing your exam. That was the first thing. And the second thing is the debrief videos are pre recorded, because having such long debrief videos live is very difficult, because there are so many things to be told. So we faculties, apart from our work schedules, are trying to sit back at home or stay awake late at nights and record these videos and put it up for you. Certain debrief videos you might find they're slightly old, they're from the first batch. The reason we have kept certain debrief videos was those had been prepared by few people who are no longer a part of the course because of some personal commitments, but they are very well trained in their fields. If you know the recent cardiac debrief video, one of the parts was by Dr. Nandini, who because of some personal commitments is not continuing the course with us, but she is a cardiac anesthesia and critical care trained from NHS Singapore. And I felt nobody else could do justice to videos on ECMO and mechanical circulatory support devices better than her. That's why we have retained her videos. Whatever extra we are finding important points or notes we feel has not been mentioned in prior videos or these question papers, we are trying to add up and increase the course content, making sure it is still concise and crisp so that you can go through all of them apart from your O's or Fink or Washington, whichever you are reading, which will also help you for a good revision. Don't worry about revision. These quiz sessions are actually for that. I'll request Navneet if he can put up the course schedule to just tell you that these quiz sessions at the end of every month are like a basically revision session for you. And the end of it, you will have 2 detailed mock exam sessions, where the pattern will be like your IDCCM exam, 3 hours, no negative marking, 100 questions, and you'll be given a scorecard. So have patience, read, don't get flustered seeing so many things in your Google Drive. You will I mean, I can tell you Dr. Suchismita can actually tell you better that how was her preparation with us. But before that, we start with Dr. Suchismita and you get to know her journey. I'll request Dr. Tapas and Dr. Sanand sir, who are like our course directors, also to say a few words about the course and how it has been going till now, and introduce Dr. Suchismita.
Thank you, Dr. Alisa. I would now request Dr. Sanand to say a few words. Sanand, are you there?
Yes, Tapas. Sorry, I was in a phone call from the hospital. So
Yeah, Dr. Sanant is the consultant intensivist at Townsville Hospital. I would like to know from Dr. Sanant his introduction, and he is the course director and also co-founder of 360 Critical Care Academy.
yeah, welcome all for this. I think it was a scheduled debrief that Alicia has planned, which is a very good initiative so that we all stay connected and the interactions in the group can continue actually. And if you have doubts and everything, or especially if you have any specific topic that you need us to focus on or talk about a little bit more, or few doesn't have to be only one topic, few of the topics that you want some clarification or want to know where to study from, or things like that, this is the best session, and this is the way you can interact with the faculties also. I think till now the group is doing well, and as we can see from our previous efforts, that the topmost student is I will not say from or studied totally from our academy, but at least we helped her a little bit, I believe. So that's a feather in the cap, I believe. So hopefully this course will help you out with the time that is remaining. And the only request for the candidates will be to stay focused, because we try to concise everything in a course with 2 or 3 months, which is not at all equivalent to the whole knowledge gain process that you get throughout your career. But we try to do our best as much as we can, make you ready for the exam. But it's a continuous learning process, so be serious for these 2 3 months so that you can capitalize the course material. Thank you, Tapas.
Thank you, Dr. Sanant. And I will not take much of your time. I will be just highlighting the journey of the TRICS IDCCM course. This is the third batch, and over last two sessions, the questions, the preparation, and the enthusiasm among the faculties is like we will be saying they are like dedicating most of the the topics as well as the time to how you will be getting the best out of the course. And the course, the IDCCM exam is also evolving. Last 5 year back the IDCCM the exam, and today the IDCCM, it is getting tougher and tougher every session. And I would definitely request as well as recommend that you have to go into the details, because this is the National Indian Society of Critical Care Medicine apex exam, and the examiners are very learned, and they want that you should know everything, at least about the common topics. They will not give you excuse that the hospital doesn't have the liver transplantation facility, the hospital has not having the ECMO facility. At least you should know it's not accepted that at least the hospital is having basic things, because they are expecting that if you are not going for the DRNB or DM exam, so IDCCM is now taken as one of the highest qualification in the critical care, and is equivalent to EDIC 2 also. EDIC 1, EDIC 2, as well as the DRNB and DM in most of the corporate hospitals. So you need to be focused, as Dr. Sanand as well as Dr. Alisa has told. So the course demands that your focus and your attention throughout the 3 to 4 months, and our faculties would be definitely guiding you at every step to do better. Thank you very much for joining us, and I would now request Dr. Alisa to please continue.
So, as both sirs correctly said, focus is most important. We can give you the materials, which I've already stressed from day one, and all the support, but you have to sit and study and make that time every day. I just put up the schedule for people who have not joined the course and are attending the free quiz session also today. That this quiz session is actually after completion of 4 modules: OBG, nutrition, neurology, ID, and cardiology. Again, after the next 4 modules, we'll be having the second quiz session, and finally 2 dedicated mock exams. And by 28th March 2025, we hope all of you will be ready for your IDCCM main theory exam. Now, without further delay, I'll ask Dr. Suchismita now to please share her experience. We are very happy that she was a student from the second batch. It was a great pleasure. I still remember Dr. Arun calling me up one day and asking that I took the viva of a candidate named Dr. Suchismita. And she was somehow answering everything on spot. I really don't know, like, how is it possible? I thought she must, like, I told, maybe, she's really well read. And he was like, you won't believe the way she was answering. Try to take her exam. Her second mock exam, and be a strict examiner. But I told I'll see, because of some commitments I couldn't take her exam. But yes, I'm very happy that what Dr. Arun saw or felt that day, we never knew that this was going to be the future. And when Dr. Tapas put up the message that day in the group, You know, it was a very happy moment for all of us. Seeing all of you pass with flying colors is what we want, but this is definitely an icing on the cake. So, Dr. Suchismita, if you can just share a few words about your journey, how you prepared with our candidates.
Okay, thank you, Alisha ma'am. From my side, I had to join initially in June. My exams were on 12th September. From June, I joined your course, and one thing I have to say that it's the syllabus is unending, isn't it? It's a huge thing, and everything, and so it's the basic concept to build your concept, reading books and all during not the 3 months are just the revision part. No, obviously you have to you have to know your what you are studying and what is the means the basic knowledge of all the topics. Now that is the most important. So after I joined, and each and every all those MCQs and the study materials also went to with our 360-degree 60 critical care provided those continuously. And see, some things are priority in life. Everybody now during the exams now I also have a family, kids and all, but some things are priority in life. So at this time I means gave priority that I have to finish this course in one go. I have to complete it successfully. I did not think I'll get this much achievement like a topper, but just one thing is I have to clear it in one go in the first attempt. So it was a really difficult journey. I read day and night. Even I means managed duty with my colleagues and all. So then the materials provided, the MCQs provided, you have to go to lots of MCQs because studying everything is not possible, covering everything. But MCQs gives you an idea of how you'll what is expected from you and how you means whether you know the basics or not. Even when I gave the exam, I felt that yes, this MCQ I've tried before. I should answer. But when I saw the options, that all are different. That means this so much varied questions the examiner said. Now, so you have to be thorough on the basic things. Unless we know the basic, just some things like we say, ratta maro, like this, all those doesn't help always. But and one thing I'm very grateful to our faculties, they give in the study materials also, even during the debrief videos also, they give us lots of mnemonics to remember. Some things are really, without the help of mnemonics, you can't always remember all the things, especially those poisoning, all the symptoms, toxicology, those part really it helps, needs. And also in the practical session, this mock test builds confidence. You know what is expected from you and how to answer, and you get a very short time to think of it. They don't. It's very rapid fire round, isn't it? Even in the mock test which our faculties conducted, and especially in the main exam also, it's you get very little time to think. So you have to be clear and confident and not beat around the bush. By chance, if you don't know it, the more you answer, the more rapid fast you answer, the more time you get to, because they have a fixed set of questions. So if you in that fixed time, if you answer slowly, you will miss on the last questions. So somehow you have to finish it up fast, and so that the examiner gets more time to ask you more questions. And one thing is, some topics you have to be supposing electrolytes and all those. Lots of questions came from electrolytes, from the ECG readings. In MCQs, I'm telling the theory part. No? So those things really, unless you know the basic concept of that, only just last moment reading won't do. So you have to give time and read. These last 3 months are really very important. So please give some time. Think this as a priority, and we need to make use of these last moment revisions.
Thank you very much, Dr. Suchismita. What she told was very true, right? One thing that at every point of life, you should know what is your priority, and you should actually prepare according to that and work according to that. So now the priority for the next 2 months till March is your IDCCM theory exam, which all of you should ace without any issues. And tips from her are going to help. Like she told, right, whatever materials we give, whatever help we do, eventually you will have to take out time every day and sit and study. We can just be the support you want, but effort also has to come from you. Thank you, Suchismita. I request Tapas sir and Sanand sir to congratulate her on behalf of all of us from TRICS-IDCCM.
Yes, yes. So that's like no great news, and somebody in like the elite class at the national level, and India is like there are like I am part of the college board, so I know this time around 450 people have appeared the exam. So coming out as the number one out of those 450 is a like no big feat, and definitely we are congratulating and we are privileged to have you, Dr. Suchishmita, today. And she also responded very positively, and she has also taken some time out of her hospital duty to join our this online debrief session to share the tips and tricks. So thankful to you always, and may you shine even better and better, and miles to go before we sleep. Yeah, thank you.
Thank you so much, sir. Thank you.
Dr. Sanand, anything? Yeah.
Yes,
Yeah,
sir.
thank you. Thank you, Dr. Suchishmita, for logging in. I
Thank
mean, you have done well. I would urge not to stop here, so there are other avenues to aim for. There are,
you.
it's a learning process. So the
Yes,
day
yes,
day somebody thinks that I'm done, then probably they are dead. So
mm,
it's a learning process. Think of something else as a next step,
yes, yes,
and
sure.
I will wish you all the luck. All right.
Thank you, sir. Thank you, sir.
Congratulations.
Thank you, sir.
So thank you. So without further delay, I think the debrief video will start with. Thank you, Dr. Suchusmita, for joining
Thank you
us.
so much. Thank you so much, ma'am, and all the faculties for helping me for this achievement.
So before like Alisa, anybody out of our faculties, Dr. Arun, if you want to share, or like anyone wants to share one or two line about Dr. Suchishmita or congratulate,
I
you
think
can.
Dr. Arun should speak, sir,
Yes,
actually.
yes, yes. That's why I told Arun. Yeah. Arun, are you there?
Yeah, yeah. Good
Yes.
evening.
Good evening. Good evening.
My video is, yeah. So, no, I think she did wonderfully well in the mock test. I still remember because as I have taken some people, but she was perhaps the best amongst the candidates that at least I have interviewed or I have taken the mock test. And at the end of the test, I told her that you will come out with flying colors, although I did not know that she will come out first. But at least
I
she,
made one big mistake while in the ECG part.
the
That
good part was she was answering what is required, nothing less, nothing more, and timely. The only thing I told her, I think I remember, is to not to forget the basics, because sometimes what we tend to do, we think this is presumed and examiner will understand. Like, for example, you have to give oxygen in a case of pneumothorax. So simple things that we need to keep, as everyone also says, that you have to stick to the basics and tell the basics. Don't presume that the examiner will understand things. You have to tell. And hope you come out with flying colors in futures also for other exams, for other things. All the best.
Thank you, sir, so much. I really want to thank you. You gave me a lot of confidence in that mock test. As it was the last one just before my actual
Yeah, yeah,
practical exams.
yeah.
Thank you.
Okay, thank you.
Thank you.
Thank
Thank you, Arun. Yeah. Okay.
Uh, so we'll move ahead with the debrief session right now. Request Dr. Priya, one of our faculties, who will be, taking the debrief video to the detailed debrief session today of all the quiz questions you have prepared. In the interest of time, we'll let her finish the debrief part. If any of you have doubts, please post it in the chat box so that we keep answering it. And in case time gets over, because we have to wrap up the session by 8 o'clock, we don't want to take too much of your time. You can post it in a WhatsApp group. Otherwise, you can keep posting your doubts in the chat box. All the faculties who are online right now will answer it. Okay, over to Priya.
Yeah, so hello, good evening, everyone. So this part of the webinar is going to be the answer reveal for the quiz of the day. First off, I hope all of you did well and scored a solid 10. So now before we begin, let me make one thing clear. It's not another class. We wouldn't want to consume your precious time. I'm sure all of you all are busy with duties and stuff. So this session isn't about reteaching, but about realigning you with the course schedule. Think of it as a mini revamp of the sessions we've covered so far. And, to just help you consolidate your understanding and moving forward. So this quiz isn't a standalone event. It's a part of a bigger picture. So there are more topics coming up, and in about a month, you'll face another quiz. So consider this as a checkpoint, a way to see where you stand and reinforce key concepts and, fine tune your approach. So we'll just keep this short, crisp, and to the point, just answers and explanations. And at the end, we'll have a doubt clearing session. So keep your minds open and, have your questions jotted down. You can ask any of the faculties during the webinar. Okay. Is my screen visible?
Yes, it's visible. Yes.
Yeah. So the first question, in which of the following conditions is it recommended to delay the enteral nutrition in critically ill patients? So the answer was uncontrolled hypoxemia and acidosis. So the explanation is that ESICM guidelines suggest delaying enteral nutrition in critically ill patients with uncontrolled hypoxemia and acidosis. Initiating enteral nutrition in such unstable conditions may exacerbate the patient's critical clinical status. So once these issues are settled, and the enteral nutrition can be considered. So why not other options? In case of controlled shock, enteral nutrition can be initiated in patients with controlled shock as a hemodynamic status is stabilized. And in case of stable upper GI bleeding, if the bleeding is controlled, it can be cautiously initiated. And regarding the GRV, if it is less than 500 ml for 6 hours, a gastric residual volume below this is generally acceptable for initiating enteral nutrition. So this was pretty much an easy, straightforward answer. I hope all of you all have gotten it correct. So the second question was, what is the ESICM recommendation for managing gastric intolerance during enteral nutrition in critically ill patients? So the answer is, administer prokinetic agents like metoclopramide or erythromycin. So the explanation goes, so the committee recommends prokinetic agents like metoclopramide and erythromycin to manage gastric intolerance during enteral nutrition. So gastric intolerance is often due to delayed gastric emptying, and prokinetics enhance gastric motility, thereby improving tolerance in enteral nutrition. So those drugs, metoclopramide and erythromycin, what do? Metoclopramide is a dopamine receptor antagonist that increases gastric motility and accelerates gastric emptying, whereas erythromycin, it acts as a motilin receptor agonist, promoting gastrointestinal motility. So studies have shown that the combination of these agents can be more effective in refractory cases with significant reduction in GRP and improvements in calorie intake as well. So why not other options? Stopping enteral nutrition and switching to parenteral nutrition immediately. It is not recommended as a first line of approach unless enteral nutrition is completely contraindicated or it fails entirely. Parenteral nutrition is associated with higher risk of infection, hyperglycemia, and other complications. And gastric intolerance should be managed with interventions like prokinetics, adjusting enteral nutrition strategies before considering parenteral nutrition anytime. So evidence-based guidelines including ESICM and ASPEN emphasize maintaining enteral nutrition whenever possible due to its physiological benefits and low complication risk. Next option was reduce the rate of enteral infusion and wait for improvement. Well, this can sometimes improve intolerance. This approach may lead to inadequate calorie and nutrient delivery, which is detrimental in critically ill patients, as we know. So it does not address the underlying issue of delayed emptying, making it a less effective solution compared to prokinetic therapy. Guidelines recommend proactive measures like the prokinetics that we are going to use to optimize enteral nutrition delivery rather than simply reducing the rate. Perform routine GRV measurements every 4 hours. Not consistently recommended in modern clinical practice, evidence suggests that routine GRV checks do not correlate well with aspiration risk or feeding intolerance. Both European and American guidelines discourage routine GRV monitoring in patients unless there are specific concerns like high risk for aspiration. Overemphasizing on GRV can lead to unnecessary interruptions in enteral nutrition, and it always contributes to underfeeding. So the current focus is only on clinical tolerance signs like abdominal distension, vomiting, rather than fixed GRV thresholds. Yeah. Can I go ahead?
Yes, please.
Yeah. So the next question, What is the most appropriate statement regarding the use of immunonutrients in critically ill patients? So the answer was the use of immunonutrition should be individualized as their routine application remains controversial. So the decision to use immunonutrients such as glutamine, omega-3 fatty acids, or arginine in critically ill patients should depend on the individual patient's condition and clinical context. It is always tailor-made. So routine administration is not universally recommended due to mixed evidence of efficacy and safety in conditions like sepsis or multi-organ failure. So why not other options? Glutamine supplementation is beneficial and should be given to all patients receiving parenteral nutrition. No, evidence does not support the routine use of glutamine in all critically ill patients, especially those with multi-organ failure. Omega-3 fatty acids must be routinely used in enteral nutrition for all ICU patients. No, the benefits of omega-3 fatty acids are condition specific, such as in ARDS, and it is not applicable to other conditions. Arginine may worsen the outcomes in sepsis due to its vasodilatory effects, and it is generally avoided in these conditions. Moving on to the next question. In critically ill patients receiving vasoactive drug therapy, what is the primary concern when administering enteral nutrition? So the primary concern was the increased risk of gastrointestinal ischemia. Explanation is that vasoactive drugs like your norepinephrine, dopamine, adrenaline cause vasoconstriction to maintain systemic perfusion during shock states, but they can reduce planktonic blood flow, leading to ischemia in the gut. This may also impair the ability of the intestines to tolerate enteral nutrition and can result in complications like bowel necrosis or non-occlusive mesenteric ischemia. So gradual advancement of enteral nutrition is recommended with careful monitoring of signs of intolerance like we already said, abdomen distension, high GRV or lactic acidosis. So why not others? High incidence of aspiration pneumonia risk. While aspiration pneumonia is a concern in critically ill patients, it is not specific to those receiving vasoactive drugs alone. Proper measures like elevating the head of the bed, monitoring for signs of intolerance can mitigate this problem. The use of vasoactive drugs does not increase the likelihood of aspiration, making this a secondary rather than a primary concern. Next was severe fluid imbalance. Vasoactive drugs can affect the fluid balance, but administering enteral nutrition itself does not significantly contribute to the fluid imbalance. Fluid imbalance is typically a result of underlying critical illness or the vasoactive drugs themselves and not enteral nutrition itself. So increased mortality due to delayed feeding. So delayed feeding can have negative outcomes in the priority of patients on vasoactive drugs, but ensuring hemodynamic stability before advancing enteral nutrition. Guidelines recommend starting trophic or minimal enteral feeds early if tolerated rather than delaying feeds entirely. Mortality concerns are more related to prolonged underfeeding or inappropriate initiation of enteral nutrition in unstable patients, not due to the delayed feeding in patients on vasoactive therapy. So next question, which pharmacologic agent is most appropriate for improving right ventricular contractility in acute right heart failure secondary to pulmonary hypertension? The answer is very straight, it's milrinone. So in acute right heart failure secondary to pulmonary hypertension, milrinone is often the pharmacologic drug of agent because of its dual action of improving the right ventricular contractility and reducing the pulmonary vascular resistance. So coming to the mechanism of action, as we all know, it is a phosphodiesterase 3 inhibitor that increases the intracellular cyclic adenosine monophosphate levels, leading to increased myocardial contractility, that is positive inotropy, and improving right ventricular function. The second main mechanism is that vasodilatation of pulmonary and systemic vasculature, thereby reducing pulmonary vascular resistance and afterload on the failing RV. So milrinone is particularly effective in patients with pulmonary hypertension or elevated pulmonary vascular resistance as it directly reduces the afterload on the RV while enhancing the contractility also. So studies suggest it improves the hemodynamics and oxygen delivery in these patients. So why not dobutamine? So it is a beta-1 adrenergic agonist that enhances myocardial contractility and is commonly used for RV failure. However, its effect on pulmonary vasodilatation is minimal, making it less effective in reducing the afterload on the RV. So additionally, dobutamine can increase the heart rate, which may worsen the myocardial oxygen demand and ischemia. So beta blockers are generally contraindicated in acute right heart failures as they reduce the myocardial contractility and the heart rate as well. While beta blockers are used in chronic heart failure for long-term benefit, they are inappropriate in acute decompensated scenarios like RV failure secondary to pulmonary hypertension. So why not dopamine? It is primarily used for hemodynamic support in hypotension. While it has some positive inotropic effects at moderate doses, it does not reduce the pulmonary vascular resistance. At higher doses, dopamine causes vasoconstriction through alpha adrenergic stimulation, which can increase the afterload on RV and it can worsen the pulmonary hypertension. Next question. So, which one of the following statements is accurate about decompressive craniectomy in refractory intracranial hypertension after traumatic brain injury? So, the answer was it increases the survival, but with a higher risk of severe disability. So, the explanation is mainly based on the trial Rescue ICP. So this is a key study which addressed the use of decompressive craniectomy in patients with refractory intracranial hypertension following a TBI. We already know. So the trial demonstrated that decompressive craniectomy improves survival in patients with TBI and refractory intracranial high intracranial pressure. But this survival benefit comes at the cost of increased risk of severe disability. So the patients who were in the trial who underwent decompressive craniectomy had higher survival rates compared to those who received only medical management. However, those who survived after the procedure were most likely to have severe disabilities like including motor deficits, cognitive impairments, or long-term dependence. So the explanation is very clear. It straight away says why not the other options. So does it improve 6-month functional outcomes compared to medical management? Yes, it improves the survival, but does not significantly improve the functional outcomes at 6 months. The survivors after surgery are more likely to have severe disability rather than improved functional recovery. So it reduces the ICU stay, but increases long-term mortality. So it has not been consistently shown to reduce ICU stays significantly. In fact, those who are undergoing a craniectomy will obviously have a longer stay in the ICU, but it does not increase the long-term mortality as well. So it is recommended for patients with ICP of 40 mmHg only. So while an ICP of more than 40 is a common threshold for considering decompressive craniectomy, the Rescue ICP trial did not set a strict cutoff for ICP in its inclusion criteria. So the decision to perform decompressive craniectomy is based on refractory intracranial hypertension, meaning ICP that does not respond to medical management and other interventions, and not just an arbitrary threshold of 40 mmHg. So next question. In the management of delayed cerebral ischemia following aneurysmal SAH, which of the following interventions is most evidence-based for improving outcomes? So the answer was maintenance of euvolemia with individualized hemodynamic therapy. Why? The management of DCI after aneurysmal SAH focuses on ensuring adequate cerebral perfusion to prevent secondary ischemic injury only. So evidence supports maintaining euvolemia and hemodynamic therapy, which includes judicious use of fluids and vasopressors to optimize CPP and prevent ischemia. Studies have demonstrated that a target CPP, typically between 60 and 80, helps reduce the risk of ischemic damage, improving patient outcomes. The benefit of maintaining euvolemia also avoids complications like fluid overload, hypotension, both of which can again worsen DCI and the outcome. So why not others? Prophylactic administration of high-dose nimodipine. So nimodipine, a calcium channel blocker, used to prevent the onset of DCI and improve cerebral blood flow after aneurysmal SAH. However, high-dose nimodipine has been shown to increase the risk of hypotension without offering added benefit over the standard dose therapy. Standard doses are recommended based on evidence that they maintain efficacy without inducing harmful side effects. Therefore, high-dose nimodipine is not recommended for improving outcomes in patients with DCI. Routine use of intra-arterial vasodilators in all patients with DCI. Why not this? So, intra-arterial vasodilators such as verapamil or nicardipine and can be helpful in managing refractory DCI, but they are not used routinely. The routine use of these agents is not supported by evidence as they carry risks such as vessel injury, complications from induced vasodilatation like exacerbation of vasospasm or hypotension. So instead, intra-arterial vasodilators are typically reserved for patients who fail conservative management or have persistent DCI despite other interventions. So induction of therapeutic hypothermia to prevent vasospasm. So therapeutic hypothermia has been investigated in several clinical trials as a potential strategy, but there is insufficient evidence supporting its routine use in this context. So studies have not demonstrated consistent benefit, and hypothermia can cause it has its own pitfalls like infection, coagulopathy, and cardiac arrhythmias. So next question, pretty big question. So a 40-year-old patient undergoing induction chemotherapy for acute myeloid leukemia develops persistent fever despite 5 days of broad-spectrum antibiotics. The patient is neutropenic with an ANC of less than 500. A high-resolution CT reveals nodular infiltrates with a surrounding ground glass halo. Serum galactomannan is positive and BDG is elevated. Despite initiating voriconazole therapy, the patient's clinical status deteriorates, with worsening respiratory distress and new cavitary lesions on repeat imaging. What is the most appropriate next step in the management? So the answer is add caspofungin to the existing voriconazole therapy, a combination therapy. So why? So in patients with refractory invasive aspergillosis or clinical deterioration, despite appropriate monotherapy, combination therapy with voriconazole and caspofungin is supported by evidence as a salvage strategy. Caspofungin and echinocandin inhibits fungal cell wall synthesis, as we all know, and can act synergistically with voriconazole. This approach is particularly useful when there is radiologic progression or clinical worsening despite standard treatment. So why not others? Switching to liposomal amphotericin B as monotherapy. So while amphotericin B is an effective alternate for invasive aspergillosis, switching to it in a patient already on voriconazole may not offer additional benefit, especially given that the combination therapy has shown better outcomes in refractory cases. Amphotericin B is preferred as first-line therapy in patients intolerant to voriconazole or when mucormycosis is a concern. So perform BAL to identify resistance pattern before modifying therapy. BAL may definitely confirm fungal infection or detect resistance patterns, but delaying therapy modification in a critically ill patient is inappropriate. So empiric adjustments based on clinical progression is only essential in this setting. So continue voriconazole and monitor for clinical improvement over the next 72 hours. Clinical worsening despite voriconazole therapy suggests treatment failure or the possibility of resistance. Delaying therapeutic escalation can result in rapid disease progression and increased mortality. Next question. Which pharmacologic therapy has the strongest evidence for reducing mortality in patients with heart failure with reduced ejection fraction? So this is also a straightforward answer. Angiotensin receptor neprilysin inhibitors, ARNIs. So ARNIs, the sacubitril valsartan, had the strongest evidence for reducing mortality in patients with heart failure with reduced ejection fraction. The paradigm heart failure trial demonstrated reduced cardiovascular death by 20% and all-cause mortality by 16% compared to enalapril, making it the first-line therapy in HF-REF patients who tolerate RAS inhibitors. So mechanism of action, you have to understand. Sacubitril, a neprilysin inhibitor that prevents the degradation of natriuretic peptides, especially the BNP and the bradykinin and other vasoactive agents. This thereby enhances vasodilatation, natriuresis, and diuresis while reducing the cardiac remodeling. Valsartan, an angiotensin receptor blocker that inhibits the renin-angiotensin-aldosterone system, reducing vasoconstriction, sodium retention, and myocardial remodeling. So the dual mechanism addresses both neurohormonal activation that is via the RAS blockade and natriuretic peptide augmentation, providing superior benefits. So why not digoxin? Digoxin primarily used for symptomatic relief by enhancing contractility and controlling the heart rate in patients with AF. However, digoxin does not reduce mortality in heart failure with reduced ejection fraction. The DIC trial showed that digoxin reduces hospitalization for heart failure but has no significant effect on overall survival. Also, it has a very narrow therapeutic window, posing risk of toxicity. So why not furosemide? This loop diuretic provides symptomatic relief by reducing the fluid overload and improving pulmonary congestion and acute exacerbations of heart failure. However, it does not reduce mortality or modify disease progression in these patients. Its role is limited to symptom management and improving hemodynamic stability only. And overuse, obviously, it causes electrolyte imbalances, volume depletion, and worsening renal function. Why not ivabradine? So this reduces the heart rate by selectively inhibiting the funny channels in the SA node. It is used in patients who are in sinus rhythm and have a heart rate of more than 70, despite a maximally tolerated beta blockade. So the SHIFT trial demonstrated that ivabradine reduces hospitalizations for heart failure, but does not significantly reduce all-cause or cardiovascular mortality. Its role is adjunctive, not as a first-line therapy for mortality reduction. So the last question, which was very easy. So which of the following best describes the dose-dependent effect of dopamine in the management of cardiogenic shock? And the answer would be moderate doses, that is 5 to 10 mics per kg per minute, which stimulate the beta adrenergic receptors, increasing the cardiac output. So as we all know, dopamine is a dose-dependent sympathomimetic agent that acts on dopaminergic, beta-adrenergic, and alpha-adrenergic receptors based on the infusion rate. Its effects vary with dosage, making it a valuable but complex drug in managing cardiogenic shock. So low doses of less than 3 mics per kg per minute stimulate D1 receptors in the renal, mesenteric, and coronary arteries, causing vasodilatation and increased renal perfusion. Moderate doses, which is 5 to 10 mics per kg per minute, stimulate the beta-1 adrenergic receptors, increasing the heart rate, contractility, and cardiac output. High doses of more than 10 mics per kg per minute, they predominantly stimulate the alpha-adrenergic receptor, causing vasoconstriction, which increases the systemic vascular resistance and can compromise the renal perfusion. So in our case, high doses can reduce the renal perfusion despite earlier misconception that dopamine improves kidney function. Evidence suggests that high doses may worsen outcomes, especially in critically ill patients. Low doses, they stimulate the D1 receptors, as we saw, causing vasodilatation and in renal and mesenteric arteries. This dose is sometimes called renal dose dopa, although clinical trials have failed to demonstrate the significant improvements in renal outcomes or protection. So dopamine has a consistent effect on cardiac output regardless of the dose. Obviously, no. Effects of cardiac output are dose dependent. So at moderate doses, beta-1 adrenergic receptor stimulation increases the heart rate and contractility, thereby improving the cardiac output. Low doses have minimal cardiac effects and high doses have detrimental cardiac effects. So they reduce the cardiac output by increasing afterload through alpha-mediated vasoconstriction. So that's about it. I hope all of you all had all the answers correct. So any doubts, candidates? Alicia, ma'am?
Alicia's left. She is held up with the case.
Okay.
Yeah. Any doubts from the candidates? Last few minutes, if you have any doubts, you can ask here. You can unmute yourself and ask questions, or you can post it in the chat box, or else you can ask in the WhatsApp group where we have a dedicated WhatsApp group.
No doubts? At least let us know all of you all got.
I think there are no further doubts. Like, we can end the session.
Okay.
Right. I think if there are no more, okay, somebody, can we have a debrief on heart failure? What exactly do you want in heart failure? Heart failure is a little vast topic. Anything specific you want in the heart failure? Treatment of heart failure. Okay. Maybe not a debrief. Maybe we will try to do a small PPT or something on that, and we will try to share it in the group. Okay, if there are no further questions, we will end the session. All the best for your future exam, the future mock test. Please kindly attend all the mock tests so that your last final mock exam will be easy. Thank you.